Hello, everybody, and welcome to Simulation Nation. Today, we are talking about everything that is pre-briefing and debriefing and how to master that, along with talking about standardized patients and how that comes into play in your pre-briefing and debriefing.
I think this is one of those topics that when we first started, or I first started in simulation, there wasn't a whole lot of information out about what we were supposed to be doing. Or even
pre-briefing really wasn't even.
No, it wasn't a thing.
Yeah, no, that really wasn't on the radar.
No.
Yeah.
And debriefing was kind of catch as catch can. Very much like I would have done in a post-conference in clinical, because there just wasn't a lot of guidance out there. It was like, we need to talk about it. But it came pretty quickly after I started in 2006. But I think that the really amazing thing from my perspective is to see the evolution over time. And that when we started to get really good practices out there, again, simulation is based off of the military and aviation. And that's how we knew we were supposed to be doing a debrief.
We're like, oh, you guys are doing that? Yeah, no, we'll do that too.
But even the idea of a pre-briefing really came about, and I can't necessarily give credit specifically to Harvard, but I think a lot of the work about psychological safety came out of Harvard, and it really brought to light some of the things that we could do as simulation facilitators to make the simulation actually better. I think what pre-briefing really does is it prepares your students at the level they are and gives them a level playing field. You know, it's really no longer, hey, I know everything as the facilitator about the simulation. Now you go in and figure it out and let me tell you how well you did, you know, which was, I'm embarrassed to say probably, but that's pretty much what it was in the beginning, at least for me. And
I think it was also this sense of like, I'm going to mentor you now. I just watched you perform. Now let me give you all of the things that you did wrong and the things that you need to make improvements on for next time, you know, because it was like, all right, I saw you without the awareness that is the time for them to learn. And I think that that's the difference, is now we see the debriefing as the place that they're learning, the place that all of the pieces are coming together.
It's the reframing, right?
Yeah.
And so that to me is, you know, rather than just like, okay, I need to make you a better nurse, so let me just fix you here in this, here right now.
In this 15-minute section, I'm just going to fix all of the problems. Yeah.
And I think that, again, it's come such a long way, and it's really been exciting to kind of be in the beginning of that wave and ride it through. And I think, let's get back to pre-briefing, because I think that even though debriefing, I think they actually say that 60 to 80% of the learning happens during the debriefing phase. And so such a small portion of it happens during the simulation that getting that debriefing is really correct.
Yeah.
But if you don't have the students prepared properly and not anxious to go into that simulation experience, then you're cutting everything off at the feet, because they're just trying to get through it and get out.
You're just starting off on the wrong foot, because that's not the intention. We don't want students to be going into simulation nervous. We don't want them going in feeling like they're at a disadvantage or that they could potentially, failure and things along those lines. We want them to go in as confident as possible with all of the resources, opposed to trying to trick them during the simulation.
Right. And again, the other important thing I think for facilitators to remember is that these students probably have had other interactions with other facilitators. And it's just like healthcare. If they have had a negative facilitator simulation experience, they may carry that with them into the next piece. So the more that you can do to set that groundwork for them, the better. And Axel has their healthcare simulation standards, and they have, within their standards, they have a whole section on briefing and debriefing. Pre-briefing and debriefing. And so, again, that's really your first go-to fundamental resource for if you're trying to get down to the nitty-gritty pieces of it. But the essence of a pre-briefing experience is really to give your students everything they need in order to be successful beforehand. So some of the important essential elements to think about are, what preparatory work do you have them doing? If they've learned about something in the classroom and they've been tested on it, it's potential that you don't have to do additional, preparatory work for that student to come into that experience. But typically the students, whatever you're doing a simulation in, they're struggling with the concept. So as an example, I had an instructor who was actually a course instructor come to me and tell me that the students are struggling to understand the difference between acute renal failure and chronic renal failure. And so we did actually a double sim, so it was a multi-patient sim, and they had one in acute renal failure and one in chronic renal failure, and that really drew out the concept or the information. And then we actually had some students, well, I guess one semester they tested on acute and chronic renal failure before the simulation, and their test scores on average were lower than the ones that had the next semester when we did it before they went in and were tested on the content. So that, again, that just highlights some of the really cool learning experiences.
Yeah.
It's a Kirkpatrick too, but it's really, again, you're able to bring out some of those more difficult concepts so that when they're learning.
And they're seeing it and experiencing it.
Right. But I think that the idea of pre-briefing is you've got some of that essential content, making sure that they are prepared with the knowledge that they have. And I will say that I wasn't the best consumer of knowledge prior to assignments when I was in college. This generation seems to be they want to be prepared before they come. So really think about the fact that this stuff if you spend some time really looking into what you can do to prepare the students, you can really make that impactful for them.
Yeah, one question that I get a lot, I think more from newer simulationists, is this concept of, I don't want to give them all the answers. I don't want to give them this shrug, hey, this is going to be stroke, make sure you're prepared for that stroke before you come in kind of thing, and giving them all the answers. But then I've heard it on the other side of, well, if they're not prepared, then they feel tricked and they feel like they didn't have the ability to come in, with their best foot forward. What's your opinion or your stance on kind of, is it too much information to give them all the prep work and they kind of know what's to come? Or, because that's not real life, or should they have the information so they can come with their best foot forward?
So we had a very similar question at the George Washington Sim Summit just last week. And what they said was, I don't want the objectives to reveal what the students should be doing because I feel like I'm giving away the answers. And I think, again, it depends on the level of learner that you have. I will say that we have written, at Avkin, we have written simulations for nurse residency programs. And within those, we have learning outcomes that are learning objectives that are shared with the learners. And then there is also a set of learning objectives that are not shared. So that could be much more specific, but they are expected to be at a proficient or competent level if they are at that. If they are there. If you have novice learners that are in fundamentals or in their first med surg course or something along those lines, or early on in any of the psych or specialty courses, I think that Crystal said it best to say that you can put the objective there. That does not mean that they remember it or that they are able to achieve that in simulation. I know a perfect example for us was we talk a lot about it, but we did a depression assessment simulation where it was a patient that was in a med surg unit, and that patient had attempted to kill themselves, but it wasn't clear on the chart. But within their objectives was that they performed a depression assessment as well as a safety assessment. And by and large, I would say about 25% of the groups that came through actually did that assessment. So putting those objectives in and being clear does not necessarily mean that you are giving away any answers. Even giving them preparatory work that is very specific to the patient that they're going to see is not necessarily going to give away the answers.
I do think sometimes as instructors, there's this mindset of you're taking the simulation and almost thinking how you would handle it or how you would approach it. But oftentimes they have years and years of experience. These students just coming in to perform, almost they could read a script of what you want them to say. They're still going to have challenges going in. Now, again, it depends on the level of learner, but it's still going to be a challenge. Even if you wrote out, here's your safety assessment, here's your depression assessment, having those words come out naturally is still going to be a challenge. And Absolutely. I think sometimes there is an overestimate of skills and abilities that having those students come in and feel completely unprepared, we don't want our students to feel duped or tricked or scared of simulation. We want them to come in and feel like they're going to be successful, and then we can always go back to that in the debriefing. But I think that rather than shying away from giving guidance to these students, leaning more into giving guidance is what's going to make the simulation feel like they were able to really prepare for what was going to happen and understand it. And again, that's kind of an outside perspective as someone who is the standardized patient in the simulation. But I think that oftentimes that's what I see, is that there can be an under assessment of what the student's abilities are.
Yeah, I mean, I think...
an over confidence in what the student's abilities are.
I think Nicole Hardner said it best, and she talked about simulations being designed to stretch the students to the edges of their ability. Mm-hmm. And I think when you create simulations that are appropriate for the level, appropriate for the coursework that they have completed, appropriate for the patient interactions that they are going to have in their clinical experiences, the more that reservation or that concern gets removed.
Yeah. So let's get back to pre-briefing, because I feel like we've gotten off track a little bit. So
it's okay.
The other pieces that would be included is that preparatory work in the pre-briefing.
And I think the other, again, if you are using mannequin simulation or something that may be not as authentic or realistic to what they're going to experience in a clinical environment, the fiction contract is a really good one. And again, some people even struggle with standardized patients and virtual reality. And
can you walk through what that fiction contract has included in it?
Well, basically what it's saying is that we've done everything that we can to make the simulation as real and authentic as possible, and to allow you to practice to the full extent of your profession, because you have different disciplines, right? So, but there's going to be an essence of lack of realism, and we just ask that you do your best to fully immerse yourself in that experience. So that's really what it is. It's just let's identify here that it is not exactly the same as what you're going to see with a patient case.
Yeah.
But again, from my perspective is with a patient, especially with SP simulation, it's not nearly as difficult. But a patient who is depressed, and I see that one patient, I could go in the next room and see a patient who's depressed, and that patient is very different. A very different presentation, a very different conversation. So they have to be flexible and adaptable in their own professions, down the line. So that's what the fiction contract is really just, hey, we've done our best. We just ask you to do your best and to fully immerse yourself in this as much as you possibly can.
Yeah.
And I think that the other really big piece of that conversation that you have with them is the idea of, we believe that everybody here is capable, knowledgeable, and is doing their very best. And that's a paraphrase off of what they put out at Harvard, but it is written on the walls in many sim centers that we have visited. And I think that it's also a great reminder for facilitators, because there are times where you think that they should be at a certain level, or that you think that this simulation should really,
they should be easy.
Yeah, they should be able to demonstrate this very well, or whatever the case may be. And if that doesn't happen, it can be that you want to revert back to that we need to fix them here, right now kind of concept. So I think it's a good reminder for the facilitators to read that at the beginning of every simulation, as well as the learners to hear it.
Yeah.
Again, I think that's a great reminder. And even if a simulation doesn't go so great, reading it again right before debriefing might be a great idea as well.
And I think also the concept of what happens in the sim center stays in the sim center is the other part that is very important, looking even just at psychological safety of kind of, in theater, they use the term of like wiping your feet before you walk on stage, and wiping your feet when you leave. It's that concept of like, I'm leaving everything here so that you're not taking things home with you. You're not thinking about it constantly. You're not, putting your self-worth into it. And I think that it's a very similar thing within simulation where, if that simulation doesn't go as great, leave it in the sim lab, as well as for peers that are participating, that you don't want peers to go around and talk about others' performances and things like that. And then you go back to, just generally also not wanting them to share the secrets of the simulation to other people. But I think there's many reasons why that's an important sign or statement to have in your sim center, is reminding them that this is a safe space. What happens here stays here.
Yeah, and I think that many people actually do that at the beginning of every debriefing as well.
Yeah.
Just to remind them that, we're here to help each other grow and learn. I learned so much from my students.
Yeah.
I really did along the way. So, just the idea that we can learn from each other and that we can share that knowledge. When COVID hit and we had to switch everything to virtual, we took clinical cohorts. So we had 8 students and we had them do these simulations as a clinical cohort. And it started as, it was basically one fluid simulation, but each one of them had about 5 or 7 minutes with the patient. And we would do mini debriefings in between each one. And one of the things that the students said, that as far as the evaluations, that they loved about that experience was they got to see their cohort interact with the same patient that they had, and observe it, do it in an observational role. And they loved the idea of being able to, I saw the first 3. And, I'm definitely going to take this into my clinical practice based off of what Susie did or whatever. And I think that was really eye-opening. And the other thing they loved was the mini debriefings, because they felt as though those debriefings helped to get them back on track and helped the conversation to be focused on that particular patient presentation. So, you never know. Yeah. You never know what students are really going to appreciate. So, but you do want them to be learning from, with, and about each other,
I think the other really crucial part with the pre-briefing is doing a room orientation before the simulation starts. Yeah. I think that it starts it off where you are very comfortable as a simulationist in that room. You're the one who stocked that room. It makes perfect sense in your brain. Depending on where these students are, like some can be techs, in the hospital and see things very differently. And I think sometimes we don't go into it with the mindset of like, if I was brand new walking into this room, where would I assume things will be? I think a lot of times we do the best that we can with what we have, but being able to bring them in and show them where everything is, I think takes out a lot of anxiety and stress that comes with the start of that simulation, because then you're not necessarily saying like, oh, part of the simulation is now you have to figure out where the medication is, or you have to figure out where the syringes are. Like, they're aware of where everything is, opposed to going in and now it becoming a scavenger hunt to try to find the things that they need. Because in the real world, that's not what we're actually looking for, right? We're not looking to see if they know where those medications are. They're obviously going to understand how to get access to all of that. And it's going to be a very different process that's not simulation. But I think all of that's important. Orienting them to the mannequin, letting them know, this is where you find the pulse, this is all of that. I've heard of doing one large at the beginning of the semester, but I think it's always good to do refreshers. I think, again, when we're in and out of those rooms all the time, it makes tons of sense where everything is. But to understand that these students aren't in there day in and day out, I think that it helps at the beginning of the simulation to make sure everyone understands, aware of everything, and then can kind of go forward from there.
Yeah, I mean, I've seen people do like a scavenger hunt at the beginning of a semester, or a video orientation. What we chose to do was to have a clean utility area. So we showed them where that utility area was. But for each simulation, we would show them or have them find, okay, you have a patient with a tracheostomy. Where is the trachea cleaning set? Where's the suction? So that they weren't looking, like you said, spending time looking for where it is. And I will say, as a healthcare provider, I spent a lot of time looking for things. If I was going into a new clean utility area, or if they had gotten, Foley catheters, if they'd gotten a different kit, and because I was looking for the old kit. I mean, we just visually go and look for what we're used to. So we did try to keep that setup the same, but you introduce different equipment into that. So like, think about the code cart being introduced. That needs to have an orientation, making sure that they understand where the sharps are, how the sharps are disposed of, all those things are really important. The one thing I will say is, if you do utilize standardized patients in your simulations, or if you're new to it, I highly recommend that you don't have the standardized patients in the room while you're doing the room orientation.
Do not.
Don't introduce them. Hey, this is Susie. She's going to be your standardized patient for the day.
Don't even introduce them as, this is going to be your patient for the day, because we're out of character. So like, until the simulation starts, we're not ready for that. That has happened. It's always the surprise. It kind of feels like someone like walked into your dressing room, but I have had that where they've gone to do, like, someone might have asked a question. So they go in and take them into the room to do the orientation. I'm sitting there as a standardized patient ready to go. Curtain gets pulled. People are walking in, and it's like, what are you doing here? This isn't supposed to start yet. And again, a lot of times it's, oh, this is your patient, so-and-so, we're going to get, and it's, even though you might still introduce me as the real patient's name and things along those lines, I'm still not in character, so I don't look like that patient at that point.
Yeah.
I might be on my phone. It's still very disorienting. Just move your standardized patient out of the room or pull the curtain, whichever is fine, just as long as there's not this uncomfortable eye contact with these people, especially if you're supposed to be like in pain or other elements of the simulation to make it authentic, because it comes off so, it's kind of like just like you deflate the balloon. It's just like because everyone gets taken out of the situation.
Yeah, we had a case of we used mostly students, so college age students. They were taking a 3-credit course for our standardized patients, and the one case was a patient with cerebral palsy, and our sim center for doing those sims was up on the 2nd floor.
Mm-hmm.
So sometimes they were coming from class, so I would meet them at the steps and give them the crutches and let them walk into the simulation space with the crutches as if they were, because it was a student,
mm-hmm.
but they could still have their backpack and all of that. But you don't want them to see a patient who has a spinal cord injury and is paraplegic, but they're walking into the sim, things along those lines. So just, again, be cognizant. We didn't have any special back alleyways where our SPs could come in, but we sequestered them in the control room while we did the room orientation, and then had the students step out of the room to get a game plan and strategize for a couple minutes. And then we would have the SP go back in and get into character.
There was a lot of bells and whistles to make it work for how we had it, because the sim lab was not set up strategically for standardized patients, which is another point, that if you are building a sim center and planning to use standardized patients, you need to bring in someone to help with that process before you build your sim center, or else you will be in a similar situation where we were, of trying to, again, please step out of the room and do this. Now, I would say I don't think the students ever knew that that's why they were being asked to move or step out or whatever it is, but we did actually have to have a really good plan for the flow and the functionality of it. And for me, the big thing was always that if it didn't make sense why the patient should be walking into the room, like if the patient should have already been there for 2 days, that was always a really big challenge, because we didn't want to throw it off that they were just walking in for the first time or something along those lines. So we had to work really hard to make sure that those standardized patients were not seen before the actual start of the simulation. The other component to consider, if you are going to have standardized patients, they need somewhat of a pre-briefing of their own. So considering that they need to know what time of day it is. This was something that was always confusing until the very end. We finally got it right. But it was always, is it 8 in the morning or is it the current time of day? And everyone was always confused which it was. But that plays a huge part as a standardized patient, that if you're pretending it's 8 in the morning and you just woke up for the day, but it's really 2 in the afternoon, so the students think it's 2 in the afternoon, you think it's 8 a.m., you're playing it very differently as that patient, and it gets confusing very quickly what's wrong, because they're pretending it's 2 in the afternoon, and you're acting like you just woke up for the day, and they're like, what do you mean? You've already had lunch. And you're like, right, I was just taking a nap. So that always gets very confusing. So make sure everyone is on the same page with the time. I've heard of sim centers just making it that it is every simulation starts at 8 a.m. or every simulation is the time of day that it's actually happening. But making sure that that's standard across the board is huge, just for, again, making it more realistic. The other component is making sure that they are aware of what the handoff report was. So when they last got their pain medications, when they ate last, things like that will help with any confusion. So we did one sim where I remember it just so happened that this one got off track, and they had asked the patient when they got their last pain medication. This wasn't something that we had in RSP pre-briefing, and it wasn't something that we had in their character description. So when they were asked, they said, an hour ago or 5 hours ago, I'm due for some, I think. I'm starting to experience pain. And the students were told that they just got pain medication an hour ago. Well, now all of a sudden, the students are wondering if this is someone who's seeking pain medication, and the whole sim starts to change because they start to become very leery of the serious patient, where that's not an objective or anything. It just so happened that that's how it came out, and then all of a sudden that patient is now suspicious. So making sure that that kind of information is handed off to that patient, again, helps with just those kind of really obscure situations where then the objectives start to go off the rails a little bit in terms of what's going on.
And then one of the things I would add to that is, so handoff report is part of the pre-briefing as well. I would write out the handoff report so the students could read that during their preparatory time. But I would also give it to them. And I would give it to them like a nurse would. So taking just, again, a few extra minutes to read that handoff report and allowing them to ask questions just like they would. Again, preferably doing a bedside report if you can, but just depending on how it all works. I think that's a big part of the pre-briefing experience for them. And I would recommend, as far as pre-briefing goes, is that there is actually like a script that is created for each one. So the objectives, you kind of go through the fiction contract and the confidentiality and the belief, and maybe even you're discussing what style of debriefing you're going to have at the end, the handoff report, and then the objectives that are in for the simulation. All those things are included, and then that script is really kind of posted in the control room.
I think it gets so repetitive that if you don't have it as a script, you don't remember from time to time. You don't remember what you said. So then if you don't have that script, almost in a way, check off what you're going through. You're like, did we discuss fiction contract or did we not? Like, exactly. You start to get goofy.
And what I've heard from a lot of people is that, they don't, the facilitators could be adjunct faculty or something along those lines. So anyone that is new to it, or even, again, just it's a good reminder, but just having one of those for each one. So when you write your simulation, you write a pre-briefing script for that simulation as well.
The other thing I think is that we haven't touched on that would go along with that pre-briefing is the safety word. And I think that is important that gets reiterated in your pre-briefing to your standardized patient and even posted throughout the room. So
not to your students, not to your learners.
What?
The safety word.
The safety word should also be to your students so that they can end the simulation if they need to. So that basically everyone has access to that and everybody knows what that word means. So that then they're given the opportunity that if they
I've never heard that before.
That's what we always did. And so that everyone in the room had the opportunity to use that word if there was ever a call, like if there was a question of anyone's safety or their psychological safety. It was used before a student fainted once, where they were in simulation and said it, and then they fainted. And so that then they were able to kind of go in and do something right before it happened. But it's that idea of them being able to use a word. You don't want it to be common. You don't want it to be something like stop or, something that's just casual in conversation that can come up, but something that's, off the wall. So we used the word code Bravo. That's what we had, was code Bravo. And that would mean, the simulation, that something was going on and that everyone needed to be aware of it. But we had it posted everywhere so that the standardized patient could use it if there's any concerns, the students could use it, and faculty could use it if there was any concerns. But basically it was an understanding from all sides that if this word's used, that everybody is able to
I've heard of the safe container, but I haven't heard of the safe word for learners, and that's an interesting concept. One of the things that I think is also really important is, and this may happen at the beginning of the semester, I just always tried to remember to include this in the pre-briefing as well, is if you are out of any kits or any equipment that you needed, a lot of times we were out of thermometer probe covers or something, that you would say out loud, I'm going to call Clean Supply to get some more of the, thermometer probes. So we knew from the control room that you were out of something. And the same with medications. If you were looking for a medication and you couldn't find it, don't spend the whole time looking for the medication. Say out loud, I'm going to call pharmacy to get a restock of this medication so we can make sure that we're doing it. When you're doing back-to-back simulations, sometimes things don't get restocked properly or something happens. So rather than spending your whole simulation time looking for something that isn't there or trying to figure out why it isn't there, don't assume that you're being don't assume, this is what I would say to the learners, don't assume that you're being tricked. Just say out loud so that we can make sure that
you're aware that we don't have
that you have what you need in order to be successful.
So one last thing that I just want to say, because we've talked a lot about the pre-briefing side of this, but one last piece for the standardized patient that I think it only ever comes up when you've been a standardized patient, but the idea of having the motor running before simulation. So this was something that we would always teach our standardized patients, that let's say there's two of them, if you're playing a husband and wife in a simulation, I want you to already be talking as the door's opening. I don't want you to wait for the doors to open before you start the conversation. One thing that we learned was whenever we are doing something that would be physically very taxing for the standardized patient, so going into cardiac arrest or having extreme 10 out of 10 pain, we did not...
Just to be clear, we weren't doing CPR on our standardized patients.
No.
They would then revert over to the mannequins.
Yes, they would start with a person, but then they would move over and do the CPR. But when they're doing something that's extremely taxing like that, we did not want them to be in full character throughout the entire pre-briefing because it was a very long time for them to be short of breath or in that extreme pain and things like that. So what we had to do was find the right balance where we wanted the motor to be running before the students walked in the room, but we didn't want them to be doing it the whole time. Part of it was that we wanted it to be believable where they were listening to the pre-briefing, like hearing what was going on in the patient's room. Probably stress-inducing, probably shouldn't have had it that way, but that was the thought at the time that that's more believable. So what we learned later on was that right before the students were going to walk in the room, we would do one last pass with the standardized patient. Hey, you good? Do you need anything? All good to go. And then basically we would say, when I leave the room, your motor's going to start, or the next person to walk in the room is going to be the students. But we would always do a knock on the door, or we would just let them know as soon as I close the door, motor starts.
Yeah. So when we had an SP educator, they could go in and check. But as a facilitator, I didn't have time. So I said, basically, as I knock on the door, it's time.
Yeah.
And so I would knock, and then the students would have a chance to get, 2 or 3 minutes to get themselves a game plan, and then the simulation would begin. So the second knock was actually them coming in. The first knock was me saying, okay, start.
Yeah.
And I think that was a really good balance because if you think of, maybe parents of a pediatric patient, you want them to be talking about, the other kids, if they have other kids, or the dog,
who
or
walked
trash,
the dog last,
or whatever, because they wouldn't just be sitting there with their hands folded waiting for the simulation to begin, right? They would be living their lives the way that they would normally be in a stressful, probably, environment because their child's now in the hospital.
Yeah. I remember when I would do it as the 10 out of 10 pain patient, I remember it was so hard to keep it up. I probably was the one that advocated for this, was like, we can't be in pain this long. But I remember I was supposed to have 10 out of 10 back pain. And by the time the students would come in, I'd be like, I'm exhausted. And so I'd have to put the pillow around my face so they couldn't really see my face. Because I can remember squinching my face so much I'd get headaches. So I'd have to do all these creative maneuvers. And I just remember being like, I'm acting my heart out here and no one's even here to watch it. I need to save the good stuff for when the students come in the room that then I'm actually, on.
Yeah. Plus it took a little bit of time because they were setting up the PCA.
Yeah. Oh my gosh. It would always be notorious. That would be 45 minutes of 10 out of 10 pain and be like, yeah, keep it going, keep it moving. I was like, oh my gosh.
45 minutes is a slight exaggeration, but yes.
An hour. Hour and a half, actually.
Not quite. Okay.
So moving on to pre-briefing or debriefing.
Yeah. So debriefing, it's harder to have a script, in my opinion.
Mm-hmm.
I think it is, again, that kind of setting the stage and, letting the students come in the room and just reminding them of the confidentiality. And then if it's going to be recorded, again, having that conversation, or if they're going to be watching video of themselves to share that information. Because it makes some people uncomfortable to watch video of themselves. I know I don't love it personally myself. So, but I think that those pieces of it or those aspects of it could potentially be scripted. But then the debriefing style or model, there are multiple different styles or models out there.
Yeah.
And more have entered on the scene in recent years, and every simulationist, the people that have been doing simulation for a while, they have their own preferred style or method. But if you actually kind of break down most of them, I think Plus Delta is very different than the rest of them. But the rest of them, pretty much, you could kind of see how they could fit together. Of okay, we're going to let the students diffuse and de-roll, and so giving the students time to just ask any questions that they have and talk about anything that really was a struggle for them. But I like to start with having the students talk about what they thought that went well, because people, just our brains are naturally wired to identify the things that we did wrong. So to ask them what they did well from the start would have them actually have to reflect.
Yeah.
Because the things that they did wrong, they probably could roll it off their tongue. And they're so hard on themselves. So to make them actually think through some things that went well, I think was the best way to get started. But again, the model you use, you have to fit it into the way that it's going to work. And my recommendation is that every sim center identifies a specific model of debriefing. That model of debriefing is not only identified with the facilitators, but the facilitators are also telling the students, hey, we're going to work through these different stages. And for us, it was a 3-step model. We're going to work through these 3 phases of simulation. And that allowed us to make sure that we covered all of those pieces. So again, what model are you going to use? Every sim center, adopt the one that you're going to use, and then you're giving that to your new simulationists.
I think it's preferred by the students too when it is consistent throughout the whole sim center, just because then they kind of know what to expect. I think that when it varies, it's harder for the students to be able to anticipate what's coming next and how it's going to flow. I think it's almost like if you hear a song that you're very familiar with and then it's kind of like, it's changed in some sort of way, it kind of just feels like, it just doesn't feel as next? Right. But I think that if it's natural and you kind of know the flow of it, it's a lot easier to follow all the way through. So that's why I would always recommend for sim centers to kind of choose one and then everyone is trained on that. If not, I think it can get really confusing. Then people start to merge different pieces and models, and
I mean, again, from my perspective, novices need to be introduced to it. Having lots of choices sometimes is confusing. My opinion is, and it's not necessarily everybody in the simulation world's opinion, but most, even when you're going through accreditation, they want to know what style of debriefing you teach, what method and what model, and what how that's being taught to your facilitators.
And I would say Pearls is probably one of the most common. That's the one that I probably hear the most. The one that we're more familiar with is the 3D model. And so again, that was something that we adopted very early on at the university and used that consistently all the way through.
I latched on because it was only 3 steps I had to remember.
Yeah. But I would say that just from what I've heard, I would say that Pearls is probably the most widely adopted.
Yeah. I think Debriefing for Meaningful Learning is also one that is pretty well adopted too. Again, just know that there are multiples out there and that there's not any one that's right or wrong, but you do want to make sure that you are being intentional with what method or what model your sim center is using and what method or model you're introducing your novice simulationist to. Because if you don't introduce them to a model, they will just go back to whatever mode, and typically it's the clinical instructor mode of what did the students do right in there, what did they do wrong, and the students walk out and have not done nothing now, but they're ready to beat themselves up, and they're not even sure if they want to be a healthing provider anymore. So
especially if it doesn't go great. Yeah.
Of course, I'm exaggerating, but you know what I'm saying is that it has been proven, and it not just by the healthcare simulation industry, but also in aviation and the military, that allowing people to reflect on their actions and allowing them to think through why they made the decisions that they made is what is going to help to reframe that learning experiences. What were they seeing, feeling, hearing? What were they sensing? And I love the new National Council of State Boards of Nursing model, where they talk about you identify cues or clues from your patient, you come up with hypotheses, you test those hypotheses, and then, again, you're intervening along the way. So to me, it's very easy to, think about it in that fashion or form.
The other thing that we hear a lot is that when you include a standardized patient in the debriefing, not having them take over the debriefing. I think that that's one of the most common things that I've heard, is that when they want to include someone, that they almost steer away from it because they feel like they can't control it when there's another person in the room. So number one, there's some logistic challenges that come into play because we do want the students to be removed from the simulation room for that debriefing process. So being able to have the SP be able to go in that room as well, that means that they're going to need some time to write out their feedback and then also be able to move into the debriefing room. That also goes back to your strategy when you're designing your sim center, of having that debriefing room attached to that sim room is the ideal, because then your standardized patient can very easily move over and join the conversation. So that's step one. Step two, though, goes to training. And that's what I tell people anytime they're concerned about standardized patients taking over or sharing too much or taking it in directions they don't want it to go, is that it all comes back to training. And so the same way that we're training those standardized patients to play the role of the patient, we also need to train them on feedback. And one of the big things that I teach any standardized patient coming in is feedback that you are giving is a part of the debriefing, but it is not the debriefing. And I think that that stage has to be set, that we're not all just sitting around waiting to hear what you have to say, that there's a lot of components and there's a dance that goes along with this. And you are here to enter into that, but you are not there to take over. And something that we always train standardized patients on was that when the facilitator would say, I'm going to take the reins back here, that meant you're talking too much and the facilitator needs to take back over. So that was their cue to understand that it's time to move, to the next step of what needs to happen, just to stay on time and relevant and all of those other components.
Yeah, and sometimes the feedback didn't have necessarily something exactly to do with the objectives. I mean, again, I think that by and large they tried to hit the objectives, but if it was not cued into the objectives, or if it was maybe a little clinically based and they should not have been giving advice, like talking about, how they were held first in a certain position or whether the blood pressure, that was really my job as the clinician. So again, just saying, I'm going to take the reins back here and let's have a conversation, because sometimes, though it may not necessarily be comfortable for the patient, it is something that they have been taught in their courses that they need to do, right? Yeah. They have a professional responsibility. But I also think the other concept behind this is that you can also cut them off and say, I'm going to take the reins back here, so they know. And we would do that during the teaching. They would know if I said that's what it was. But also in the midst of the debriefing, again, and I use this example all the time, but it's a perfect example. We had a depression assessment where the patient wasn't clearly suicidal, as I was talking about earlier. And if they'd gotten all the way up to asking the safety questions and had built rapport and had done their depression assessment, but they hadn't actually asked the questions about suicidal and homicidal ideation, we would talk about that during the discovery phase of the debriefing. And if the student said, well, and typically this is what they said, if the patient said yes, that they were suicidal, I didn't know what to do next. So we would discuss that. Well, tell me what you think you might do. What did you learn anything about in class? Was there anything in your preparatory work? That kind of thing. And so if they were, if I could tell that they had, oh yeah, now I remember what I'm supposed to do, I would say, well, let's just practice that in the debriefing. And we could ask the SP to get back into character and go right back to that point in time. Again, if you have video, you can show right up to it and say, okay, this is where we're going to hit it, and allow them to practice that, because it's just a couple of questions and a couple of, but it was really interesting to me when I first did that, because the SP can set the mood, even though I'm now as the facilitator in the room with them, and it's, we're even in a different room, but that mood just comes so quickly back that it really benefited the students to be able to walk out of there saying that they had asked those questions.
Yeah.
So don't be afraid to introduce that concept or idea, but just make sure you're just limiting it to just a couple of minutes of time, because in debriefing, you only have so much time.
Yeah.
I think that the other big aspect of the debriefing process is there's sometimes where, especially during that diffusing or derolling or that beginning phase, when you're asking them what they thought went well and what they could have applied, what they've applied from prior simulations or their clinical practice into this, again, just getting them to start thinking through.
I really like that question, though. When you ask that, I think that that's so important. What have you taken from other scenarios to bring into this one? I think that that is a very thought-provoking question that always leads to really good conversation.
Yeah, and again, you're asking them to reflect, right? And it's not just what did you do wrong, right? But it's the next phase of like, what did you bring in? Oh, I did. I came in and I sat down and I whatever, So again, the more you can get them to think about that, and it's really kind of asking them, what did you do well, without saying what did you do well, right? But the other piece of it, and then again, what can they improve on? But during that time, they could also ask questions. And there's times where it's an appropriate question for the SP to answer. So it might be, I didn't know what to say when they did this, or they said this, or I didn't know how to explain this in the right way. And I would always say, that's a really great question. Let's put it in the parking lot and make sure that we ask the SP that question during the during the discovery phase.
Yeah.
Because I think that there's times where, as the facilitator, I could probably answer it, but it becomes so much more credible when it's coming from the person who was playing the role of the patient in that room. And there's actually research out that says that they care more about what the SP thinks of them than the facilitator. So in that way, I'm facilitating even more because I'm allowing the facilitation between the SP and the learners to happen, which is really, the more you can step back and just let the conversation happen is what you want.
Yeah, absolutely. And I think that those can lead to just really powerful moments of them being able to see, here's someone who, again, I have no background with them. I don't know them. They're only here to help me with my learning and my education. But I think that is a culture that has to be taught over time. When we started, when there would be, do you have any questions for the patient? Is there anything else you'd like to ask them? A lot of times they refrain from asking those. And over time, I believe that because there was so much thought and consideration from our standardized patients put into their answers and being very thoughtful with their answers, they learned, oh, this is going to help me in my next sim, or this is going to help me with clinical. And I think that trust started to form more and more. And I think it was a culture that really got built between nursing students to standardized patients. And it was a conversation that would happen between those two, where they were able then to be more vulnerable and ask those questions of, well, is there anything else I could have done differently? Or how would you have wanted me to handle this situation? But I think that if it's not in the beginning natural and easy for them to ask those questions, keep at it, keep that trusting relationship going, and making sure that those standardized patients are going to answer with thoughtful responses, because that's how you build that relationship where it really is just a dialogue then between the patient and the students to gain more insight.
And I would say, as far as facilitation, model that. Ask the SP questions. I would always say, this is you'll never, think about an end of life simulation. You'll never be able to ask the parents, how did I do it telling you that your child just passed away? Like that's such an inappropriate thing to do in clinical practice, but here it's appropriate. So take that opportunity to ask questions. What are the things that you're walking away wondering that didn't get covered in the feedback from the SP or in the discussions or the questions or whatever? And I do think that the culture changed. And again, I attribute it to the healthcare standards of best practice. I could attribute it to all of the things that we have learned along the way, right? It's kind of like stepping stones. In the beginning, I think the students were nervous. And I think that it was more of you did this right, you did that wrong. And then as we went to more reflective questioning and got models of debriefing, but the more you can make it we are here to help you. This is again, if it's a formative simulation experience, we are here to help you. This is not being graded. This is to help you become a better nurse. And I would always say, again, in the pre-briefing, these simulations are created to stretch you to the edges of your ability. And so we understand that you might struggle with a few things or a few concepts, but this is the time where you can take all those things that you've learned in the classroom, or maybe you've struggled with in a clinical setting, and practice them in a safe way. And what I heard from my students that had gone off into clinical practice and came back is that they had so much more confidence than they felt that their peers were, people that were hired that weren't from the same institution that I worked at. So to me, that was, again, I'd love to have data on this. We never collected it, but we I would love to have data. I think the other thing that I would say as far as debriefing goes is the deepening, the final stage of asking them what they've learned from this experience and what they're going to take with them and what they're going to try to apply into the next simulation, those types of questions. It was always rushed. It was always, always, always rushed. And it was so frustrating. And again, I think we had some really powerful debriefing experiences, but it's almost like setting a little alarm clock that when you have 5 minutes left. And the other thing that we did that really helped to facilitate a full conversation during the debriefing is we would do 2 half-hour sims. So it was a 10-minute sim, 20-minute debriefing. we would do 2 sims, so basically an hour simulation, and then we would not schedule the next one for 15 minutes. So
it made scheduling a nightmare, but
yes,
we did it.
It did. It made scheduling a nightmare, but as a facilitator, I had time to go to the bathroom.
Oh yeah.
If things didn't go
well, and I mean, it's just
sideways.
it's also kind of a dream world if you think that your simulations are going to end on time every single time and you're not going to face other
30,
issues.
40, 50,
oh
60
my gosh,
minutes.
yeah.
So, that's kind of like going to a doctor's office and having to sit for a long time. That wasn't fair to the learners.
And once you're behind, you're behind.
Yeah.
Like, you can't really make up that time unless you start to take away from other students.
If you have another simulationist, I mean, again, I was chief cook and bottle washer, so I was everything. So just think about that. Can you self-schedule a little bit of buffer to catch up if one debriefing goes over a little bit, or if you need to counsel with an individual student that's struggling.
Your mannequin breaks and you need to turn it off and troubleshoot it, because again, like, that kind of stuff can take up to 30 minutes to power down and restart again and reprogram again. Or if you have to get on the phone with tech support, it's just any little glitch is what's going to make it where then you're backed up for long periods of time.
And the last thing that I'll say before we close this one out is make sure that you are self-videotaping and watching yourself do debriefings, because I thought I was the bee's knees. I had been teaching on debriefing, but I actually recorded myself to do a presentation on it. And I realized how much I talked. I didn't before I watched the video. Now, I will say I hadn't done debriefing for a little while, so I was a little excited to get back into the saddle again. And it was definitely a skill that you need to keep working on, right? But think about watching yourself do those, and it's uncomfortable, but again, I had to do it for a presentation, and I was very shocked.
Yeah.
But then also, and it's something that goes into accreditation, but it is something that even if you aren't looking to be accredited anytime soon, but having peer evaluations, having other people. We do, when we do the Sim Summits, we do a mini mock debriefing session, and it's really the SP kind of going off the rails, and I demonstrate how to bring them back in and the things that we've kind of discussed a little bit, and asking follow-on questions and all of those things. But I think the big thing that I didn't know how this presentation was going to land, but I wanted to do something hands-on or more of a demonstrative rather than just standing up there with PowerPoints and clicking through. And what we had with the feedback that we got was, we need entire days of this. You read it, it's just like our students. We expect them to read it in a book and then apply it in clinical practice. And simulation is really that third braid that we talk about to help them practice, take it from the book, the theoretical or the book knowledge to actual physical practice in a safe setting. But the conceptualization that they can read a style and then understand exactly what that means as far as how to facilitate a debriefing. But the more that you can have peer reviews and make recommendations, there are some models out there. There's the DASH model, there's a PADI model. So, ways to do some peer evaluations, just like our students sometimes are a little nervous to have things done. I don't know that it necessarily makes us feel comfortable to be reviewed by our peers, but we're only going to get better from those experiences. So the more that we invite those opportunities and the more positive feedback that you can get as far as ways that you can make improvements or things that you're doing well. And I will say, one of the things that I never really thought about, but standardized patients are in multiple different rooms with multiple different facilitators, and they're seeing that sometimes the style isn't, it's not exactly aligning, and not to say that you want them to be the ones that are kind of your eyes and ears, but it is something to think about as far as, when you're having debriefing conversations with your SPs of, is there anything that, about any particular facilitation method that concerns you? And we had a new facilitator that hadn't been peer reviewed yet, and there was some concerns. And that was brought forward by the SPs because they had gotten used to a certain style. And we ended up having to do some remediation with that particular facilitator. So again, it's just being aware and being open to the idea, and having it regularly scheduled, so it's not just when there is a problem that you're doing it, but that it is a natural part of the culture of what you're doing within your SIM center. And I think the more you can make that culture last, as far as we're just here to help, same like we are with our students, the better it's going to be.
Yeah, I say that all the time, that I think that standardized patients can be very underutilized in that aspect. I think that from a facilitation side, often I hear people that will say, oh, it's so cool because you get to see multiple students and they get to perform in all different ways. And I wish that my students could watch each other because they'll learn so much from one another. It's the same way as the standardized patient, as you see different people's forms and fashions of how they approach debriefing, how they approach difficult conversations, and things along those lines. And it's the same concept where you can kind of see different styles and personalities come out throughout that conversation. I wouldn't say with your brand new standardized patients that you want to kind of dive into it. But
and you also don't want the standardized patient to feel like they're tattletaling or something like that. But it is, again, if you think about the ultimate reason why you're doing simulation is for the learning to happen. So if learning isn't being facilitated and there is a concern, no matter who they are,
I think it's much more too with the psychological safety. I think it's much less in terms of are they actually, approaching the debriefing model the way that it's like, I think it's less of that. And it's more of just, is there a psychologically unsafe situation that is occurring? Because even as a standardized patient, you don't have to have a lot of training to know when this feels psychologically unsafe or that it feels uncomfortable in the room as people are approaching it. So I think that, again, you don't want to go off with just your brand new people, but from someone, again, who has their chassis and was a standardized patient, I could offer a lot of advice in terms of that, as well as coaching. I think that that's another piece that we emphasize that so much with standardized patient. You need coaching on feedback. You will continuously get coaching on feedback. Pretty much like I still get coaching on feedback. You need to be comfortable that no one has arrived and we're never approaching it that way. I think it's very similar with debriefing styles, that it's like we will all be in a continuous state of learning. We will all be in a continuous state of learning from one another, and everyone needs to be open to it because that's the culture that we're going to facilitate at this program. But if there are concerns, all I'm going to say is your standardized patients have nothing to gain. So if they are bringing up concerns, there's probably a valid reason why those concerns are being brought up, and make sure that's a psychological safe place that they can come forward and share those concerns with, either that standardized patient educator or whoever it is.
Tell them the forum of
to go through proper channels, because we don't want it to becoming something that's tattling or something along those lines. But when real concerns come up, it's important to catch it sooner.
Adversarial in any way. Yeah.
All right, so to wrap this up, I'm going to ask you a question on what is your biggest pet peeve with a debriefing. Mine, from the role of the standardized patient, is while I'm giving feedback as a standardized patient, that the facilitator all of a sudden stops listening and then starts to re-rack the room or ask the students how to spell their names, or tries to troubleshoot the mannequin or something like that. It is so distracting and so uncomfortable as a standardized patient to be like, I'm talking right now, and if you could just pretend to be interested, I'd really appreciate it. But that is my biggest pet peeve.
If you as the facilitator are not fully engaged, you can't necessarily expect that the students are going to be fully engaged, right?
Well, it's also I just gave you that respect of sitting here. Like, I didn't need to sit here through. I gave you the respect of sitting through and listening and acting interested in what you talked about. Just pretend to be interested in what I'm talking about. You don't have to be, but just pretend to be.
Well, but I think it is a culture to make sure that you are showing that respect. Again, we know that our learners value that SP feedback, and they can't deny, if you have an SP in the room, they can't deny that feedback, and they now have to own what that experience was from the patient's perspective. But I, again, from my perspective, as far as being the facilitator, we understand that there are things that are distracting you and probably pulling at you, but to give them the respect. And again, what we always did was we had that diffuse and deroll phase, and then we had the feedback from the SP at the beginning of that discovery phase typically, and we would continue the conversation with the SP if it was appropriate throughout that discovery phase. But I think the idea or the concept is you're not done. If the SP feedback is an afterthought, then it is going to be an afterthought for the learners as well.
Do not tack it on at the very end of the debriefing.
Because you can't even get to the discovery or the deepening phase. So again, I think that's really good thought processes. As far as the debriefing pet peeves that I have, mine is from the role of the facilitator. And I would say where there are students that are not engaged in that simulation debriefing. Again, if the debriefing, the biggest thing when I was doing mannequin simulation, the biggest thing was that they would say, well, it wasn't a real person, and so I would have said that if it was, or I would have done that if it was a real person. That really was, again, when it was mannequin. It was just so frustrating. But again, even with SP pieces, if it was just get me through to the next, item, let me check the box that I got this done, and rather than them truly having a time of reflection, because I think it devalues what I was doing as a facilitator. We spend so much time creating the simulations and getting ready to do these simulations, that if it's just giving them the ability to check a box like they would a homework assignment, it just devalues all the work that we've done into the simulation. So I would say that's probably the biggest.
Makes sense.
Yeah.
All right, everybody. Well, thank you for joining us at Simulation Nation on pre-briefing and debriefing. We'll see you next time.